Okay, brilliant. Thank you very much. Um, right. So I'm going to talk about chemoing with confidence. So practical protocols for the veterinary team. So yeah, just going to discuss different protocols for some different aspects of chemotherapy. So what we're going to discuss is we're going to touch on the nurse's role in chemotherapy. Going to talk about the health and safety aspects of it. Also included in the health and safety, there's going to be talking about the equipment that we use as well. We're going to discuss how to handle a cytotoxic spill. We're going to talk about extravasation and also the discharge information as well. So first, we're going to look at the nurse's role in chemotherapy. So here is the medical team at Swift Referral. So not not specifically an oncology nursing team. However, we do deal with all of the oncology side of all of the medical referrals that come in. And incidentally as well, not all of the patients that come in for chemotherapy with us are oncology patients. We do see quite a lot of patients that have got MUOs that come in quite regularly for cytarabine. So we do a lot of chemotherapy treatment with those as well. So they're not all um, animals that are coming in for oncology related issues. So the nurse's role, we can get involved sort of right from the word go, from the diagnostics. So the vets, the medics usually do their appointments, admit their patients, and then come in, give us the plan, and we make a start with the plan. So we're taking the blood samples, sending those away, or running those in house. Then also doing the diagnostic imaging as well. So CT, I think a lot of primary care practices nowadays do have CT. So something that you, if you're sort of looking at developing uh, oncology in your practice, then something definitely you can get the nurses involved in is running the CT. So we can do that under sedation. Sometimes they might have a full general anaesthetic, depending on what else we're going to do afterwards. If they're having an MRI, which it would be the case if they were having a suspected MUO, then they would have a full GA for that. And again, that is something that the nurses can run in practice, can do the MRI, send off the images for external interpretation. However, we would always look at the images first. It's just if we send them off, we can get confirmation that what we think is the case is the case, seeing sort of tumours and things like that. But then also because they're very good at looking at diagnostic images, there might be something we've missed, something quite small that's quite important for noticing in those patients. So that's quite important. And then after we've done the diagnostic imaging, we're back with the patient to help get any samples that are needed, helping the vets to collect biopsies, FNAs, get those packaged up, sent away. Most patients do tend to go home after they've had their workup done, get the results. And once we've got all of the results, it's when the vet will discuss with the owner what sort of treatment options to go for, and discuss whether they want to go for chemotherapy and what chemotherapies are available to them. So then again, we can be involved with pharmacy side of things. So ordering these drugs, we're very lucky. We actually do have a dedicated person in our pharmacy that is able to sort of stay on top of drugs. However, we it's our responsibility to keep a note of what patients are on, what protocols, and make sure we've got the right amount of drugs before they come in for their appointment and have their chemotherapy. Then there's the admits. So typically on the first oncology or chemotherapy appointment, we would probably say you book in with the vet, because quite often the owners are quite anxious, have quite a lot of questions. But following on for that, particularly if they're going to be on these drugs for quite a while, certainly with your COP or CHOP protocols, and also with cytarabine protocols as well, these patients are going to be coming in fairly regularly, so they're going to sort of get used to the admit appointments, and it's quite nice for them to see the nurses, get to know them, get to build up a relationship with them. And sometimes as well, because when they owners find out about this diagnosis and the treatment plans, there's a lot of information for them to take in. It can be quite nice. They may have asked the vet a couple of times, come back in, forgotten about it, and sort of thought, oh, actually, I feel a bit silly asking the vet again. It's quite nice sometimes for them to have a nurse there to be like, oh, can you just explain this to me again? Because it was a lot of information and haven't quite taken it all in. So that can be quite nice. And we get to see these patients. We quite like it because these patients do tend to come in on the same day, either each week if they're coming in weekly, or if they're coming in sort of every month. It's still quite often on the same day. So they get to see the same nurse and build up that relationship with the nurse. And it's quite nice for the animals as well to come in and see the same nurse, think, oh yes, I know you, and get to get to know us a little bit. We give them lots of treats to make them feel a little bit better as well. So they get a nice relationship with us. After we've done the admits for chemotherapy, we'll get the blood sample. So typically they always have a hematology taken. Depending on the patient, depending on the case and what the vet's wanting, we may take other blood samples at the same time, but typically we'll take the hematology, get that run in-house, and then show the results to the vets and make sure that they're happy that patient can go ahead with their chemotherapy, and if not, come up with a plan of action of what to do instead. Drawing up the chemotherapy. So we're responsible for drawing up the chemotherapy. So we'll work out the dose. We always get the dose checked. So you're always getting it checked with vet. So at least one other person that's a vet, and making sure that they're happy with that dose as well. And then we can draw up a chemotherapy for administration. So administering the prescribed chemotherapy. And then giving that to the patient. So we could take a lot of the sort of the heavy work away from the vet. So then the vets have got more time to sort of be looking at other patients and also getting on with other things. So that's quite good, and it's quite rewarding for us as nurses to see these patients through their journey. Most patients will go home after they've had their chemotherapy. Occasionally, if we've got patients that are having MUO treatment, so cytarabine, that's usually run on a CRI of 8 to 12 hours. So those patients will come in and be admitted for, sometimes they spend the day with us, they get dropped off in the morning, get picked up in the afternoon, the evening. Sometimes they'll come in the afternoon and they'll stay overnight. So those patients will be admitted and will be receiving nursing care from the nurses. Quite often, is actually the nurses in the wards that are looking after those patients. So it's always a good idea for everybody, not just a specific team of nurses, to be aware of how to look after these patients. And then discharging patients. So we can be involved in the discharge of these patients. We'll talk about discharges a little bit later, but making sure the owners are happy with what drug they're coming in for next, when they're coming in, happy with any medications that they're going home with, and making sure that they're happy with how to care for their patients, their pets, after they've had this treatment as well. So we can be there for support for clients. So either during the admit appointments or discharge appointments, or even if the clients are at home and they just want to have a chat and discuss things. Quite often the clients will ask about quality of life, and having a chat with them about how they'll know when the quality of life is sort of getting too low. So that's quite nice to be there and support them. We can talk about how they can monitor their pet. We can discuss sort of how they can sort of pain assess at home, and also things like that are quite useful at keeping a diary to sort of see sort of how their pet's been doing, has the pet's eating deteriorated, because sometimes it can all turn into a little bit of a blur, but if you've got it written down, you can go back and you can look and you can see sort of, oh, for this amount of days the appetite was good, and then there's only a couple of days where perhaps it wasn't so good. And that sort of thing. And we can also look at quality of life assessment sheets as well. So discussing those with clients and seeing if they'd be appropriate for the clients to use. So we can play quite a big role in chemotherapy. This is going to depend, however, sort of where you are in practice, how often you are delivering chemotherapy to patients, and how confident your nurses are really as well. So definitely training is needed and involved, and quite often as well. I suppose if you're not doing it very often, the nurses might not be as confident in doing admits and discharges. So definitely something to have a team discussion about. See where everybody is, and how happy people feel about doing different things and the different roles. So the nurse's role can be sort of what you make it into, really. Then we've got nursing considerations. So for patients receiving the chemotherapy in practice, which can also sort of be used as well for patients at home, with clients as well for some of them. So we're monitoring subtle signs of pain, so performing regular pain scores, monitoring comfort levels, alongside with their behaviour and their demeanour. Potentially, depending on what they've come in for, whether the condition was painful to begin with, but monitoring to make sure they're not developing any pain anywhere, and particularly with your IVs, making sure there's no sign of any pain there, that can indicate that the drugs are going that are not going into the vein and sort of leaking around the vein instead, and that's going to be a sort of something that we want to get in and intervene with quite soon. So, but we'll talk about that a little bit later. Then looking at things like reverse barrier nursing these patients that have got low white blood cell counts. So sort of goes hand in hand really, in that yes, we'll be reverse barrier nursing these patients because we don't want to pass anything on to them, but also if they've had chemotherapy, we're going to be barrier nursing them for our protection as well. So it kind of doubles up, and you can sort of do both at the same time really. But if they're in and they haven't had chemotherapy, then we and have had got low white blood cell count, then we would want to be reverse barrier nursing these patients anyway. Dietary modifications. So potentially these patients might not be eating quite as well as they have been. So we might think about wanting to tempt them to eat. We might be wanting to give them sort of sort of higher calorific foods to try and help them gain a bit more weight back, that sort of thing. Potentially, they might have intestinal upset, so we might be wanting to give them something bland to help with that, especially if they're feeling a little bit nauseous. We might be giving them medications such as mirtazapine to try and stimulate their appetite. So yeah, quite a big part of their stay with us is looking at their diet and making sure they're getting the right nutrients for them. Managing the nausea and the gastrointestinal upsets. So these can be side effects of some of the chemotherapy drugs. As Rory mentioned, sending them home with things like Serenia tablets, or if they're in practice, alerting the vets and seeing if we can give Serenia injections as needed, that sort of thing. In some of our chemotherapy protocols, such as if we're giving doxorubicin, then we do tend to give a meropetant injection with that, just because that is known to cause nausea in these patients. And quite often we might send them home with some probiotics just in case, particularly with our patients being sort of travelling a little bit further away to get to us. You might not necessarily do that if you've got patients that are just round the corner and can easily pop in and get these medications. But again, that's going to be something that's decided in practice what you'd like to do. So we're going to be recording which vein we use for the IV, and we're going to alternate these IVs each time they come to see us for chemotherapy. So that's because some of these patients are going to be coming in weekly to have IV drugs given, with sort of maybe a break a week here or there, give or take, depending on what protocols they're on. But these veins do get pretty some hammer to them when they're used. So we want to try and preserve the veins for as long as possible. And with chemotherapy cases, we really are looking at trying to get an IV placed on the first attempt. So no sort of coming around and poking in and out of the vein, because then that's going to mean that the more likely to have a risk of the drugs going around the vein. So which is not what we want. So that's why it's really important for us to get that IV in first time, which means we've got less legs to play around with. So these patients don't tend to be good candidates for if you've got your vet nurses, students, and also your vet students that are wanting to have a go at practicing placing an IV. These are not the cases for them to try that on. These are definitely case for people that are already confident at placing IVs. We can place local anaesthetic creams beforehand, just to make it a little bit more comfortable for them. If they're quite wiggly, then it might be a case that we need to give a little bit of sedation just to try and make placing that IV a little bit easier, just because we don't have that many options on legs. And once you've used up all the legs, it's a case of, oh, sorry, we weren't able to do your chemotherapy today because we've got no more veins left. So yeah, we do have to be very, very careful with that. So if you've had a go on the first leg and the patient was just too wiggly, then I would say have a chat with the vet and have a look at potentially giving some sedation for that. Then we want to be monitoring the side effects for the chemotherapy as well. So if these patients are in with us, yeah, monitoring for side effects for, as we've said before, sort of the nausea and the gastrointestinal upsets. And as Rory mentioned with the cyclophosphamide, the hemorrhagic cystitis as well. So monitoring for those and alerting the vets to any signs of any of those so we can intervene quickly and get the right treatment on board because as Rory mentioned, sometimes it can be quite difficult to get on top of if these things have gone too far away. And quite a lot of these things are also considerations for the owners as well. In regards to recording which vein we've used, we'll know to try a different vein next time. Also, quite often these patients end up with a few clipped legs, and if they're getting back to their owners and the owners phoning up and saying, "Oh, his leg's a little bit red," you know, it's important, was that the vein that was used for the chemotherapy, or potentially could it just be clipper rash? Because if there's been any leakage that we haven't noticed in practice, then it would be important to get these patients in and check whether there's anything that's gone on there, or whether it is just clipper rash, and also clipper rash and extravasation is treated differently. So that's definitely something we'd need to consider. So health and safety. So yeah, there are risks associated with handling and administrating cytotoxic drugs. So these can cause abortions and fetal def def deformities as well in pregnant people. So something that we would definitely recommend anyone that is pregnant or is trying to conceive to avoid handling these drugs. They are carcinogenic and they do also cause DNA alterations as well. So again, we need to have quite a sort of big dose of respect for these drugs because they can cause some quite severe side effects to us if we are accidentally exposed to these. Looking at the route of exposure, so it can be absorbed by the skin, there can be aerosols or drug particles can be um, inhaled, they can be ingested, or you can also get them from needle stick injuries and accidentally inject yourself. So yeah, we need to put measures in place to try and minimize these risks. So how do we minimize these risks? Well, ideally, your place where you're drawing up your chemotherapy and administering chemotherapy would be in a quiet area. So you don't have high traffic. There's not lots of people coming in to distract you. Oh, um, and just on without it being. So use of PPE. So we always want to be using PPE. So even if we've got other methods that can reduce the risk to us, that we do want to be to always using PPE. So we're going to be double gloving. So you'd use nitrile gloves because they're less likely to break than your latex gloves are, and we double glove. So then if one glove did get a hole in, you've got a sort of a double up, and also when we're sort of tidying up, we can take a top layer of glove off and then finish tidying up with the bottom layer and then remove that at the end. So yeah, definitely want to be double gloving for drawing up and administering these drugs. Gowns, so we want it wants to be a non-absorbent full gown. So you want long sleeves, you want your arms to be covered, and we want to be making sure that the gloves are covering the wrist. So usually, quite often they're loop gown, so you put your fingers through the loops and then put the gloves on afterwards. If you can get any with elasticated wrists, then they would definitely be beneficial. If you can find any like that. But yeah, we definitely want to be wearing full length gowns. We want to have our masks on. These masks aren't going to sort of stop aerosols and sort of particles sort of getting in that way. However, if there was any splashes or anything like that, they would stop the chemotherapy from going in our mouth. So very important to wear those. And then goggles or a visor to protect your eyes from any splashes or any leakages that are coming up. You want your spill kit, so you want that in your area where you're drawing up the chemotherapy, in the area where you're administering the chemotherapy, and also you want it in your pharmacy where these chemotherapy drugs are kept. And we'll talk a little bit more about spill cleaning up cytotoxic wastes and accidents later on. You want your chemotherapy disposal bin. So as you can see there, you've got your chemotherapy sharps bin with the purple lid on. You can also get the chemotherapy dupe bins, and you can get the purple chemotherapy waste bags as well to put the things like the PPE and things that don't have any needles or syringes on. You're going to have hazardous drugs labels as well. So this is so you can identify your drugs that you've drawn up. So you're going to have quite a lot of flush as well, and you don't really want to be getting your flush and your drugs mixed up. I know they're probably different volumes, but yeah, if you label them, then there's not going to be any issues with those. And certainly with your patients that are coming in and having things like cytarabine over 8 or 12 hours, you definitely want to be having those labeled so everybody knows that their patient is on chemotherapy drugs. So again, how do we minimize the risks? So minimizing the risks for drawing up the chemotherapy. Ideally, we're going to use a closed and needle-free system to reduce the risk of drug spillage, and needle-free is also going to reduce the risk of us accidentally stabbing ourselves with these drugs. So all in all, ideal really. Now, these, I would say, if you're drawing up chemotherapy, you definitely really want to be using a closed system. So the examples of these are the BD seals, EquiShield. These are the ones that we've used. So you can see to the left there's the BD for seals, and then to the right there's the EquiShields. And then if you look at other products as well that are on the market, there's the Chemo lock, which it's not one I'm familiar with, but there are other products that are there that you can use. We've recently changed over from the BD for seals to the EquiShields because we were struggling to get hold of those. But the EquiShields do seem to be quite good. I have had leakages before with the BD for seals. If you can see sort of the dome there with the little sort of plaster cover over it. I have had instances where that has leaked. However, it's only a small leak, it's not sort of splattered up anywhere, and it's sort of gone directly onto the gloves, which is why double gloving is really important, and why we should always be wearing PPE, even if we are using closed systems, just because things can still happen. There's no definite guarantee, but if at least if we're using both, we've minimised the risks. And if that does happen, you can put your drug that you're drawing up down, take the top layer of gloves off, put them into their clinical waste, and get another pair of gloves to put on over. So you can do that, or potentially take both pairs off, wash your hands, and then put a new pair of gloves on, and then go back to drawing up your chemotherapy. So just to minimise any risks of exposure. But if you've got your PPE on and you're using it correctly, then you should be okay. Again, so how are we minimizing these risks? So using a fume hub or a biological safety cabinet when preparing chemotherapy. So that's going to limit the exposure, our exposure to hazardous fumes or vapors that are being drawn up. And as you can see, I've got the chemotherapy drug that I'm drawing up, and my hands are under the shield, and if that drug was to spurt out or leak, it's not going to go in my face. And I've also got the goggles and the mask on to protect my face as well. If there were any leakages, it's just going to go on my hands that are double gloved. So the sort of exposure risk is going to be fairly minimal if there is any leakage. And there's the added bonus of the of being in the fumes being taken away as well. So we have a class 2 biological safety cabinet, so it creates sort of controlled airflow environment, and has filters in to filter the air away from the operator for safety, the particles are collected and exhausted through an additional filter that's in there. So that makes it ideal for drawing up these drugs. Obviously, if I'm drawing up drugs and I'm not using a closed system or a needle-free system, I'm still at risk of stabbing myself with a needle. It's not going to stop that. And also by using a closed system with the safety cabinet, that's minimizing the risks of sort of any explosions of drugs going anywhere. I think we've all probably had it before, where I think propofol is quite a sort of quite a bubbly medication, isn't it? When you're drawing it up and it goes everywhere, or if you're making a drug up and you've got to put injectable water in, and then you come out and it sort of goes everywhere and spurts out. Well, these are definitely drugs that we do not want that to happen with. So even with the safety cabinet, using a closed system and your PPE is ideal. Now, these are unfortunately quite expensive piece of kit, and understandably, not all practices will be in a position where they're able to get them. If you're not performing sort of chemotherapy on a regular basis, if you're not doing it weekly, then it might be something that's sort of unfortunately low down on the list of things that you're able to get. However, there are things that you can do in place of that. So we can minimise those risks by considering ordering from companies such as Chemo Pet, and you can get a sort of a dose chemotherapy that's sort of tailored to that patient, and it's all ready and made up, and all you've got to do is administer it. So that removes the risks of drawing the chemotherapy up. Obviously, we do still have to administer it, so we would still recommend using closed systems for this. And also things to bear in mind are you're ordering your chemo pet drugs. If you're ordering it for the patient and then your patient's coming in having a blood test done, you do run the risk of, oh, actually we're going to have to not do chemo this time round. If you're having a specific dose ready for that patient, then there's not really sort of the options to be able to share it with, oh, it's okay, we haven't drawn it up yet, we'll just use that dose for another patient. You don't really have that as an option. So I think if you are using sort of using companies to order a sort of a ready-made dose of chemotherapy for, you have to have a think about your protocol. if you're primary care practice, it might be easy enough to get your patients in the day before, get an up-to-date weight and a blood test done, and then order it. I think they can get it delivered for after 12 o'clock, I believe. Oh, it comes before 12 o'clock, so you could book them in for the afternoon. But it is sort of a protocol that you'd have to have a look at, and see what is best for your practice. And then, yeah, health and safety considerations for these patients. So we're looking at the byproducts of these drugs that are going to be secreted in the bodily fluid, so in the urine, in the feces, in the saliva, after the chemotherapy has been administered to the patient. So different drugs are going to sort of stay in the system for different lengths of time. So depending on which drug has been given will depend on how long you need to use protective equipment to look after that patient. So ideally, while they're in that time, that sort of washout period, as it were, you would be wearing gloves to administer oral drugs, so tablets, anything like that. Maybe we're giving mirtazapine, but we certainly don't really want the patient's saliva to be on our hands. And equally, this is advice also to be giving to owners, if we're discharging them with non-chemotherapy drugs, that they should be wearing gloves as well. Obviously, if we are discharging them with chemotherapy drugs, then we would advise them to be wearing gloves, and also not to be splitting any of these tablets. Then also we want to be double bagging our feces and putting it in um, if the owners are at home, double bag it, put it in the bin as normal. However, if we're at in practice, then we are going to be using a cytotoxic waste bag. So we're going to be putting our feces in that, because we'll have one open next to the patient anyway to dispose of anything that that patient has been involved with, really, or anything that the patient's touched that needs disposing of. Urine can be washed down, and when it's outside, it can get broken down by the sunlight as well. However, it is best to walk these patients away from the other patients and away from other pets. So if we're talking to the owners, maybe advising that they go somewhere where there's less sort of less heavy traffic, less dogs going about, which also works out quite well for these patients. If they're immunocompromised, then they're sort of coming into contact with less other patients, with less other pets as well. So that's ideal, really, for when these drugs are still being secreted by the patients. We're always going to wash our hands after coming into contact with these patients, even if we're wearing gloves. We don't know if there's a tiny hole in the glove. It's not worth the risk. Just making sure that we are washing our hands afterwards will definitely be better than running a risk. And if owners are immunosuppressed, then they just need to be a bit cautious with these patients as well, because they might be potentially be more susceptible to getting other things if they're coming into contact with these the secretions in the body. The secretions from the patients are sort of a lot smaller than actually handling the drugs or administering the drugs. So the exposure is quite small. However, we do still need to make every effort to minimise exposure to this, really. And here's just a little chart that we have at work with some of the different washout periods for some of the drugs that we use, and actually, to be fair, quite a lot of drugs that we don't really use very much anymore. But yeah, this is useful for if these patients are in practice with us, we can look and see how long we need to be using PPE for, and also for discharge notes, writing on the patient's discharge notes so that the owners know how long they need to be double bagging feces and wearing gloves and being cautious for as well. So cytotoxic spills. So this is a little bit of a scarily long looking list, but I couldn't quite work out how to condense it because each step is quite important. So hopefully, if you are experiencing any cytotoxic spills, they are going to be in your designated administering and drawing up area, which would be a sort of a quiet room with low traffic anyway. So that would be ideal. Unfortunately, that's not always the case. Quite often we do have to transport these drugs from the pharmacy to those rooms. And unfortunately, I mean, anything can happen. We could trip, we could get the drug could be knocked from our from our hands. You know, anything could happen there along the lines, really. So that's why it's important to have these cytotoxic spill pads. One in the room that you're administering and drawing up chemotherapy, but two in the pharmacy, so you've got them nearby, and you can use the spill pack if needed. So if you are taking the chemotherapy drug to the room to draw it up, there's a good chance you potentially might not already be wearing your PPE. In an ideal world, your PPE would be the first thing that you put on. However, with the drugs being unopened, in theory, there should be less risk that there's anything's going to leak out. And quite often they're in boxes as well. So understandably, sometimes we're not wearing PPE at that point. So if you're not wearing your PPE, then you should put your PPE on. Now, these spill packs will have PPE in them, so that's why it's important to have them there. If you are in a quiet room, then restricting access should be easy. You could just put your sign on to say chemotherapy taking place, and people should leave you alone. However, if it's happened in the corridor on the way to the chemotherapy area, or in pharmacy, you might not have that luxury. So you need to restrict access. So you need to get other people to sort of direct people away from the area, get them to put up a sign for you while you deal with the spillage. For liquids, ideally, you'd maybe wait a few seconds for the aerosol to settle, and then cover it up with some absorbent material. So something like an Inco pad is ideal for this because it's really absorbent on one side, but then it's also waterproof, and liquids don't leak through on the other side. So they're quite ideal for this sort of thing, and they're disposable. Take care when you're doing this not to generate any splashes, because that's putting you more at risk. If you've got a powder chemotherapy agent, then you want to be placing an absorbable material. Again, an Inco pad is ideal for this over the powder, doing it very sort of carefully to minimize the dust production from that, and then putting some water on it, just to get the powder to dissolve and be absorbed into the Inco pad. You're going to gather up all your absorbable material after that. Watching out for if there's broken glass. Ideally, if there's broken glass, really you do want to be putting that into a cytotoxic sharps bin, really. So in that case, it might be that you just need to put the whole thing in if it will fit, and just sacrifice a whole bin to it, for health and safety, really. Just because if we're putting it into a cytotoxic waste bag, then if it's glass, then it can pierce through the bag, and then it can expose quite a few people to the cytotoxic agent. So yes, that's something to be aware of. Wash the area several times with a detergent. So we're going to be working from the least contaminated area inwards, and then rinsing really thoroughly with water, and then getting a dry absorbent towel, or again an Inco pad, and wiping it down. All the cleaning material, cleaning waste that was used into a cytotoxic waste bin, and then put your outer gloves into the cytotoxic waste bag, and then double bag it as an additional safety feature, just to make sure that there's no risk of it anything breaking through. If they break through and there's a hole in the first bag, then there's the second bag there as a backup for that. Then you can put the rest of your PPE in that second bag, and place the cytotoxic waste bag into the waste bin for ready for collection. Then washing your hands with soap and water, probably washing your arms as well, just doing a good thorough wash. Complete an incident report as per your veterinary practice. and make sure you can replace that spill kit. So if it does happen again, nobody's in a situation where they're without their spill kit. Now, if you've got a large spill where there's a possibility that people have been exposed to the cytotoxic agent, then it is reportable under the reporting of injuries, diseases, and dangerous occurrences regulations. So it's important to make sure that you do that if you do get a large spill where people may have been exposed to an agent. And obviously, if you think somebody has been exposed to an agent, then we would advise seeking medical advice immediately before continuing with any chemotherapy. Then we're going to have a talk about extravasation. So this is where there is leakage of the inadvertent or the inadvertent administration of vesicant drug or a solution from the vein into the extravascular area. So signs for this are going to include persistent pain, burning, stinging, swelling, and blanching or erythema of the injection site. So what are the consequences of this? So we can get tissue necrosis, we can get blistering, we can get ulcerations, and it can progress to sort of significant degrees, such as you can have it can cause permanent disabilities, disfigurements requiring surgical intervention. So tissue that's become necrotic might need to be debrided. Quite severe cases might involve losing a limb, so it can be quite a horrific thing to happen if you don't get in there and intervene quickly. So here are the stages of what we'll do. So if you think that it's happened, we would advise stopping the chemotherapy immediately. However, don't remove the IV. You can disconnect any giving sets or anything like that, but keep the IV in place. Then we need to identify. So obviously you're going to know what the drug is that you've used, but we need to sort of see what classification it comes in as. So there's 3 different classifications. So you've got vesicant, so that's one classification. So that's sort of the most the one that's going to cause the most complications. Then you've got irritant and non-irritant. Non-irritant obviously being sort of the one that's going to cause the least problems, and irritant is a bit irritating to the patient, but it doesn't usually cause as much of a horrific outcome if not managed correctly. So we're going to also assess the area that's affected as well with that. We are then going to gently try and aspirate as much of the leak fluid as possible through the catheter that's already in place. So don't put any pressure around the catheter or area. And once we've got as much of that fluid back as possible, we're going to be recording the appearance and how much volume we've got back of that. We're going to outline the area. We're going to be using a marker pen or taking a photograph so we can easily monitor what the area is looking like and be able to tell if there's any changes. Then after we've done that, now, depending on whether it's you and a nurse and a vet giving the medication, or whether it's quite often if it was it might be 2 nurses, but we would go and then notify the vet whose case it is, or the vet that's in charge that day, and they would decide on what treatment protocol they would like to give. So we'll talk about the different treatment protocols and antidotes in a minute, but we're going to start that treatment for whichever drug has been has gone outside the vein, and we're going to elevate the limb because that's going to help minimize swelling and encourage reabsorption of the drug via the lymphatic system. And we're also going to look at pain control for these patients. Do they seem painful? Do they need any further pain relief to keep them nice and comfortable? And we're then going to be monitoring these patients. So these patients aren't going to be going home after they've had their chemotherapy, they're going to be staying in for us to monitor. And depending on which drug we've used, we're going to use cold or warm compresses, and we can do that sort of between 20 to 30 or 60 minutes, and that can be done up to 3 to 4 times a day for the first 24 to 74 hours for these patients. So applying a cold compress causes vasoconstriction, so that does limit the spread of the extravasated drug, and it also reduces local inflammation and pain. However, we can't use it in certain drugs. So in our vinca alkaloids, so that's going to be your vincristine and your vinblastine, those sort of drugs, as the cold compress can worsen tissue ulceration that's caused by those drugs. So in those cases, we're going to use a warm compression for those ones, because that increases the blood flow and enhances drug removal. So these can be applied sort of, as we said, 20 to 60 minutes, and that can be up to 3 to 4 times a day. So the first 24 to 74 hours after the incident has occurred. And if they're still painful in 1 to 2 weeks, then we might be considering debridement of any necrotic tissue that's occurred. So what do we do? So what drugs do we use? We have antidotes for some of these. So the goal of the antidote is to reverse the action of the drug that's been extravased, and then that will interfere with the process of cell destruction, preventing tissue necrosis, or limit the extent of the tissue damage. So we actually only keep 2 of these drugs in practice, and that's because they are sort of the ones that are going to cause the most problems, the antidotes to the drugs that are going to cause the most problems for us. So I've put a picture of the 2 drugs that we use, if well, the 2 drugs that we keep in stock for if this were to happen. So you've got the dexrazoxine, so that is to be used if you've got doxorubin that does have extravasation happens with doxorubin, that's what you'd use. Then of course, so you've also got your di dimethylfoxide, so that is more going to be used for so a topical treatment. So that isn't something that we keep in stock, but that usually, because that is treating a drug that is more of an irritant. So we're less concerned with that, and it is something that is easy to order in and get in stock if needed. Whereas things like your dexrazoxine, that needs to be ordered specially by Chemo Pet. It's also a drug that really you need to be getting into the patients within the 6 hours after it's happened. Otherwise, it has little to no effect on the tissue. So it is something that you kind of need then and there. We also have and I'm definitely not going to pronounce this one right, that hyaluronidase. So that is for the treatment of vincristine or vinblastine, if that's leaked around the vein. So that is what we would use for that. So again, a drug that you kind of need sort of then and there if it happens. And then you've got your sodium phosphate. So yeah, again, not a drug that we keep in stock. However, it can be more easily ordered in if you need it. So if you are using those drugs, and you sort of, obviously these unfortunately are quite expensive to keep in stock, and you do have the potential to not use them, because I mean, in an ideal world you don't really want to be using them. It would be useful to sort of know where your closest practice that stocks them is. So for example, if you were quite close to us, you might choose not to keep them in, know that you potentially could either buy off us or borrow obviously it would be unfortunate if an incident happened with you guys on the same day that we also had um, an incident happen, but that would be the risk you'd run by not keeping those drugs in stock, and it's something to discuss and decide whether that is something that you as a practice want to keep in, or whether you want to borrow. As I say, with the doxycycline, if you don't get the antidote in sort of within the 6 hours, which you wouldn't be able to if you ordered from Chemo Pet, then it doesn't have a lot of effect, unfortunately. And this is just a chart which just shows some of the different protocols for these drugs. So you've been vincristine and you've been blasting. They are vesicant drugs, and they can cause pain, edema, erythema, blistering, tissue necrosis when they go leak around the vein. So when that happens, we've got our antidote there, and we can use the antidote through the existing catheter. So that's good to know. So that's another reason for not immediately taking the catheter out, for making sure we've got it in place for administering that. And then we can, as we discussed, do dry warm compresses for 20 to 30 minutes is our protocol, but you can do through up to 60, but that's going to depend as well if your patient will tolerate it. And that can be 4 times a day for 48 hours is usually what we do, but it can be up to 72 if need be. And then, yeah, your doxorubicin, which again, so that's a vesicant drug. So again, sort of the one that causes the most problems, the pain, edema, erythema, blistering, tissue necrosis, that sort of thing. So again, we want to get an antidote into that. So really important to start the antidote ASAP for that, and get a new catheter for this one. And unfortunately, this one also has to be a first stab IV as well, because unfortunately the antidote is also vesicant as well. So ideally, we don't want that going to be extravasating either. So and it does have little effect if you start this drug, particularly after 48 hours. So you do want to get in there. Then you've got your carboplatin, which is an irritant, so that causes a burning sensation, can cause pain, erythema where the injection where the injection site was. So this one is where we would be applying sort of a cold compress for this one, and then the topical antidote if you have it, but because it causes less serious effects, then we're sort of a little bit less worried about it. But it is nice to get it in and treat if it does happen. And then you've got drugs like your cytarabine, which are non-irritant. However, so they wouldn't produce a sort of local reaction, but can cause mild inflammation. And you can put a dry cold compress on these if needed. However, they don't tend to need any antidote, which is quite good really, because with cytarabine, if they're on an infusion of that, fortunately they are sort of more at risk of that happening, because obviously when you're administering your chemotherapy agents, you're there, you're able to monitor these patients, you can give good sort of flush beforehand, check that the catheter is in place, and then give the drugs to minimize the risks. Also, you've got used a sort of a catheter with a first stab, that will minimize the risks as well. Patients that are particularly wriggly might require sedation, again to minimize the risks of this happening, but it also would minimize the risks of any disconnecting and any risk to the chemotherapy splashing up at us as well. So it's definitely worth considering sedation for those wiggly patients that need it. For things like your cytarabine, because they are having continuous infusion rate over a period of time, sort of 8 to 12 hours. Unfortunately, they can move about in their kennel, and that does mean that they're more likely to have the catheter dislodged. So that's things to bear in mind, but at least that's one of the non-irritant ones. So it's every cloud. Um, and then the discharge information for owners. So I think we've sort of gone through a lot of this as we've gone through, but making sure that they know about the potential hazards, so what the drugs can do to them, what effects it can have on them, the effects it can have on their pets, what side effects to be looking out for, how long the drugs are going to be excreted after it's been administered, so they know how long to be double bagging feces, washing down urine, and some owners really like a good sort of cuddle and a lick of their pet having a lick of their face, and obviously we want to discourage that while they're on chemotherapy. So that sort of information can be quite important to them. How to deal with the feces and urine. So washing your urine away, double bagging your feces. You're going to ideally be double bagging vomit as well, and saliva. Just trying to avoid yeah, the pets licking the owners. And if there is any tablets that need to be given, ideally they'd wear gloves. So again, PPE that they need. Gloves for handling feces, urine, vomit, saliva, medication, anything like that. Medication that their pet is on, why they're on it. So if they're going home with Serenia, why they're going home with Serenia. If they're going home with frusemide, because they've had cyclophosphamide tablets, why are they going home? What are the side effects potentially as well? Because frusemide might make the patient pee a little bit more than normal. So just things for them to watch out for. So if it happens, they're not panicking. And then when they need to come back in for their next treatment, so that's really important because we don't want them to miss that. And so they know as well what treatment they're coming in for, because they know sort of if it's Dr. Rubin, for example, and they normally have I think Kristin, then that's going to be a longer administration process because that's given over half an hour. So they know that their pet's going to be in for a little bit longer. So that sort of thing. So they can plan their lives. They know what's going on. And give them these as written instructions so they know what's going on. And if they forget, then they've got it written down. And yeah, that's everything. Thank you everybody for listening. And if anyone's got any questions, happy to answer those.